Thank you, everyone. Just give them a few minutes to start logging in, and then we'll welcome everybody. Okay, let's begin. Okay, good morning, good afternoon, good evening to all the attendees and the panel. Welcome to everybody. Thank you for joining us on this webinar. I'm Mansour Faroughi from the CSF Task Force, and we're really honored to have a fantastic panel today, which I'm going to introduce. And a big thank you to Anna and the Executive Committee for helping us with these webinars. The CSF Diversion series of webinars, this is the second one of which, and there's 3 more to come, have been very much requested because of the demands from trainees and from colleagues. We know that this is perhaps the most common neurosurgical procedure, brain operation that we carry out. It is certainly the most, with the heaviest impact on life-saving and benefits in the past decades. And we're dealing with large mind pathology where excellent outcome is required and optimizing that care. And with the advances in technology and a number of procedures and shunts, and there is a greater need than ever before to become more knowledgeable and learn from the wisdom of others. And it is with this in mind that we welcome the panel with Ahmed Amar, Harold Riquet, Marianne Jola, and Andre Grottenhaus. It's an honor to have them here to carry on with this task. And a big thank you to Christophe Mifke. Happy birthday, Christophe. It's wonderful to have your presence here and to learn from your experience and your excellent engineering knowledge and wisdom. I can't think of better people to help us on this. And for well over a decade, I've attended meetings and where you have spoken on this very subject, and I've learned a lot. So thank you, and I hand over to Ahmed Amar. Thank you, Ahmed. Welcome, everybody.
Thank you very much, Mansour. Welcome, everybody. I am really honored to be with you today for the second series of our project to understand more what is hydrocephalus and what is shunt, and shunt complication and shunt malfunction. And I'm not going to talk a lot now, but maybe we'll talk at the end. But I am honored and actually pleased to introduce Christophe Betike. His background, he's in engineering, but he's the one who has really dedicated his career for understanding and developing technology for hydrocephalus management. And he actually started in 1992 a company called Betike GmbH in Germany. And then he became the CEO, and now it is a major company. And he actually dedicated all for hydrocephalus technology. I don't think there's anyone more than Christophe Betike is able to explain to every one of us in very clear words and presentation on the slides how the hydrocephalus functioning or the problem, and how is, for example, is over drainage, how does it happen. I think this is the best of thousands of neurosurgeons all over in neurosurgery and hydrocephalus and what you are doing. Happy birthday, and please go ahead.
So thank you so much, everybody, and definitely it's a privilege and an honor to have the chance to present my thoughts. And so I thank you all. I'm very open-minded to discuss every detail. I'm honestly talking about and less about hydrocephalus and more about what shunts do from a technical point of view. So I would like to share then my screen to start the presentation. And for sure, first, I would love, I would mention this conflict of interest, because sure, I'm the founder and still the CEO and shareholder of my company. Even though today we're talking about the technology regarding what we develop, or what is available in the world. And I would like to start with this slide, giving a brief comment on the importance of the development of the communication between, let's say, the physicians, the surgeons, and people being responsible in the field of development, engineers. And I'm very thankful that I met many of open-minded neurosurgeons giving their impact on our development to address this during my work and our work. So when I started, I met very early Professor Dr. Alfred Aschoff, and he always doubted whether all shunts are the same, and he wrote his PhD thesis about the different function of shunts. And based on his work, we made a lot of our own developments. But before I start talking about the shunts or the technology of devices to avoid overdrainage, I would like to introduce this basic physics. So if you look at this screen and this scheme, 1, 2, or 3, the hydrostatic pressure in these different water compartments is exactly the same. So it does not depend on the surface. It depends simply on the, let me say, tap in here. So it simply depends on the height of the water level within the container. So if I like to explain it a little bit in detail, if you see here, let's say this would be an ocean, and below the water is a connection to a compartment which is drained and has no opening to the atmosphere. You can easily understand that within this hole there would be a positive hydrostatic pressure. As deeper you dive, as more positive, as higher the pressure is going to be. So now let's assume the water was saying below the height of this opening, then surprisingly within this place, the pressure becomes negative. And if you have this in mind and agrees on that, I think you start to understand what overdrainage, where overdrainage comes from. Another drawing or example maybe helps to explain it again. Everybody has once put a straw into a glass of water, and you close it with your finger, move it up, and the water stays within the straw. But if you open the finger, it's coming out. So water is the pressure at the tip of your finger, which makes the water staying within the straw. If you look at the atmospheric pressure at the opening below here, and from there going up, means the pressure within the straw is becoming negative. So it's a negative differential pressure. So if I mention now negative pressure, I have to address that the pressure, the absolute pressure, is not stable, and it's completely different to the differential pressure. The absolute pressure is the atmospheric pressure, which depends on the altitude. So if we climb mountains at a height of 5,000 meters, we have around about 50% of the absolute sea pressure, which means then maybe 500 millibars, and at sea level, we would have 1,000 millibars. Our ICP is adapted to the change, and the differential pressure is still, let's say, 10 centimeters of water. Another slide would be this one, saying, well, here you see the average pressure in Valencia, and you see here the highest pressure and a medium pressure, and then the lowest pressure being measured over the time from 1940 to 2010. So this means people living there had the lowest ICP at this level in a range of plus 10, let's say, and minus 5 centimeters, or absolute, completely different pressure, much, much higher, but the differential pressure is still in the same range. So, but with an absolute pressure being much, much higher, and even higher in this high pressure phases. So what does it mean now for a shunted person? You see a lying person. The zero level now is, let's say, the sea level would be then the zero pressure within the abdominal cavity, which is around about the surface of the skin. And from there, you have a connection to the ventricular system, but there's a valve, and this valve is shifting this level 10 centimeters above. And which means, well, this is a sea level, let's say, and plus 10 centimeters. If you look at the point of the, let's say, foramen of Monroe, then it's not necessarily the same depending on individual situations, but this would be the positive pressure within the ventricles. Now, in the upper position, the valve is still doing the same. The zero level would be, let's say, at the upper abdomen, and from there, the valve shifts this zero level a little bit higher, and then here, this is a zero level. From here going up means, well, I'm going up, it's becoming negative. So this hydrostatic pressure has to be counterbalanced, and only this part can be taken over by the valve. And with this valve, it would establish a significant negative pressure within the ventricular system. So maybe this helps again to make it clear. So this would be the model for the abdominal cavity. Whatever is going to be drained into the abdominal cavity, it's immediately absorbed. It doesn't change the pressure situation, so it's overflowing and remains at the same level. From here, 10 centimeter opening pressure shifts it up, and then we would establish a hydrostatic pressure. Maybe this could be this one. If we move now this compartment, let's say with this value lower, this level of the water column in the upper container would shift on the same amount. So the zero level in the abdominal cavity defines the resulting IVP. So if we close the system now it's not open anymore, and we do the same, we can only see if this would be a diaphragm, then now the diaphragm with a more negative IVP pressure within the compartment would be pulled a little bit more inside this compartment. But the valve is doing the same, and the resulting pressure situation, this would within the compartment zero level. From here, it would become negative. If we turn, well, once again, look in detail in this model, we could say this zero level is shifted according to the opening pressure of the valve to the compartment. And from here, we would have, let's say, the sea level or the opening. And again, from here going up, it's negative. From here going down, it's positive. So in the line position, you can easily see this is very fine. It's shifted to this point, and we have a positive IVP around the opening pressure of the valve. But in the upper position, it can never achieve the same value. For sure, it depends on the height of the patient, and for children, it's lower, but the circumstances with the children is different. I have here this video to explain it a little bit or show what's going to happen. So we have an opening, it's dropping, and here the membrane is pulled into the compartment, and at a certain point the movement stops, and then the dropping gets slower. And still there's water, and you can see the water, but this water is not coming out because of the pressure equilibrium between the negative pressure and the hydrostatic pressure. So if we now do something, so let's say we cover, it starts dropping again, the membrane is pulled downwards, but now I place a cover above, which establishes something like the subarachnoidal space above the membrane, and you see already now it stops. And the dropping stops, and the movement stops. And now if I take away the cover, you see that it starts again dropping here, and it starts to sink again. So it's a model to demonstrate what's going to happen in shunted persons. So I was thinking, how can I show what is going to happen with the membrane? What is the force being active on the membrane? So I introduced this model and start dropping. And then you see that this membrane is still pulled, but counterbalanced with a weight on the scale to control the movement. But at the end, the force is so high that it moves up the whole weight. Here you see the weight and the model. Here a scale 200 grams, which is fixed here on the membrane. And if you observe this here in this region, you start, you see it's moving a little bit, and then you see here the movement of the weight, and on the scale that the number is constantly decreasing just because of the drops. It's dropping and dropping. The membrane starts to move, but it's kept here. And at a certain point, it's getting zero. Then the whole weight is moved up, and the weight is keeping the membrane at this position. I think to understand that explains how forces are established on the system, how hematoma and hygroma occur. So here have a model, we have a connection from this space between the cover and the membrane to a, let's say, another compartment. And the second one, it starts dropping. And here with overdraining, we pull the fluid to the so-called artificial subarachnoid space. If I add now a bridge vein and another compartment is modeling a bridge vein, it starts collecting. And if it's continuously dropping, then you have a rupture of the vein and you see the bleeding. And you can see this again on in this experiment on the movie. I think you see here the two compartments, it starts dropping. And first you see the yellow fluid, which is draining into the space. But as the pressure on everything is increasing even more, you see it becoming yellow. Now you see the rupture. So the force to open this system is overcome and it starts bleeding. So I think this is a principle which explains why and how hematoma and hygroma can occur, or at least a kind of physics which would explain that. I believe that this is a good model. So the importance of overdrainage has already been shown and reported in the early 60s or in 1966. And well, the authors state premature close of the skull after shunting is a severe problem. And this is directly connected to overdrainage. So the overdrainage is for a very long time well known, even though not systematically always addressed. If we now turn to available shunt technology, we see different types of differential pressure valves as well as hydrostatic valves. And I think only the adjustable ball and cone valves were developed to counterbalance hydrostatic pressure or to overcome problems with overdrainage. But if you look at the model again, well, this is the model for the abdominal cavity. You have a high valve pressure, you transmit this level higher, you have a more moderate negative IVP, still negative, and therefore lowering the risk of overdrainage. But now in the lying position, the pressure is by far too high, not physiological, and possibly leading to a problem. If you have this problem, you might lower the IVP, and the lying position, I think this is very fine. You get rid of the problem, but in the upper position now, as this is very low, you have a more distinct negative IVP, and hereby a very high risk to create problems with overdrainage. So therefore, I think very early, people have been thinking about how can we address that? How can we overcome that systematically? And as far as I know, the first device having been developed was the anti-siphon device. Well, this is a patent from 1987 by Rudi Schulte, who is very well known in this technical field of hydrocephalus, one of the pioneers of development of shunts. And he already introduced this device to address this problem. A scheme is shown here. Here you have an inlet and the outlet, and you see there is no connection from inlet to outlet. The proximal pressure coming from the ventricles, which might increase, is acting on a large area, and the outlet is the closed outlet has only the small area here, which is closed by this ball, let's say. So, and therefore, and the other force which have to be considered is what is the pressure outside of this device, which very often is not mentioned or seldom is mentioned. So looking at the physics of this device, look from the side, this is the membrane, the proximal force acting on that, the distal force trying to close the device. The closing force is acting on the small area, the opening pressure is acting on the large area, what you can see here. And if you calculate, if you know this equation, you can easily know that force is the area multiplied with the pressure. So, and that, as this area is very large, the influence of this function is just depending on the proximal pressure on the IVP, which is ideal. We skip the importance of the distal pressure. However, the problem is, well, the largest area where pressure is acting on is this pressure from outside. So the outside has to be movable. And what is the pressure below the skin, above the device? For example, if a child is lying on that. So during sleep, or if there's a scarf above, who can predict what the pressure is? And as we're talking about very low pressures, we have a significant influence on the functioning of such a device. So I think this limits the value of this approach. And as far as I know, clinical findings support some critical comments on that. However, what else has been developed to address that? The flow regulated devices. Again, I think introduced by Christian Sanrose from Paris in the late 80s. The idea was, well, if the average production rate is 20 cc per hour, we allow, regardless what the pressure difference is, the same amount being drained. So if the pressure is getting higher, the area which is opening is getting smaller, and therefore the resulting flow through the device remains in the same level. You can see it here it's still closed. Now it starts opening, and this arrow, this space here between the pin and this hole is getting narrowed as the member is moving further down, and thereby the flow should remain within the limits which are predicted. And at the end, it might open completely to avoid under drainage if the pressures are even very, very high. What is the problem with that? Once again, we have these 3 steps: closed, then here opened a little bit and moving, and then the last stage where it's completely opened. We have 2 principles. This is the first one. You can see here the principle A. This is what I meant with the device shown. Let's say this is a ball which is kept by the spring in this position, and now the flow is pulling the ball into this cone, and as more the ball is moving downwards, as lower as smaller the area is here in this region, and and hereby the flow might remain at the same level. Here, the other principle is something else, which has 2 pathways in parallel. One is this one, and here you see the spring which has to depress. If there's a flow, the pressure difference at this ball is pressing the ball into the seat and closing here by the pathway, and then the only pathway which still allows the flow is along the spiral with a high resistance, because the spiral is very, very thin. So technically, both principles work definitely nicely with some challenges, even though it works. What is the problem with the flow reduction device or the approach? I think we have to consider we have a production, and the production of CSF depends on time and the absorption as well. Possibly there's no absorption, then everything what's going in has to be drained along the shunt. So drainage should be production minus absorption. So there's one paper already published in the 80s by Hara et al., and they reported their findings in patients, shunted patients, where the flow or the production rate was not constant. In average, it was 23 cc per hour, but even up to values up to 100 milliliter at the REM phase in the deep sleep during night were measured. And if you have a various production rate, you should have a various resorption or drainage rate. Then you should measure that, and then you would achieve reasonable drainage. But as we cannot measure that, we cannot systematically address flow regulation, and it might lead to both under or over drainage, and it's difficult to predict, even though it lowers the risk of over drainage for sure. So the last principle I like to introduce or mention is this gravitational principle. You see this the principle here. There is a ball which is pressing another ball in the seat, and hereby closing the device. And if the pressure difference or the flow would like to drain along the device, this weight has to be moved up. So in the upright position, it's highest pressure, and in the lying position, this ball, the gravity is acting in this direction, not against the seat. So in the horizontal position, the gravitational device has no impact on the shunt. It's like an open tube. And with this angle, it's becoming higher up to maximum, and you can calculate the opening pressure with this equation. So here, once again, at an angle of 45 degrees, this device has already 0.7 multiplied with maximum opening pressure as a compensation, depending on the posture of the device. So what does it mean in the shunted patient? Here we have again the model. This is the DP valve, which is establishing this difference to the abdominal cavity, let's say from here to there. And I did just the second container to explain what's going to happen with this one. Now, this gravitational device is pulling this level up to the container here, and from there now, the differential pressure is doing this. So if once again, if you go back, in the line position, there's no shift of this level from this device. It's zero, it's the same. And then here it establishes this enormous, depending on the chosen device, the enormous gravitational compensation of the hydrostatic pressure. So far so good. If you look now at available technology, I think it's worth to consider what about adjustability. I know the debate about the importance of adjustability for many, many years now. And from my point of view, it makes a lot of sense to interfere with the individual situation, regardless what kind of technology we are discussing. So I talked about differential, adjustable differential pressure valves, but what about this one? As far as I now know, adjustable anti-siphon valves are available, or flow regulated valves are available, but gravitational valve is available. And I would like to explain what the background is. So the proposal was coming again from Dr. Aschoff already in the year 2000. And he said, well, this is a strong requirement for the improvement of the shunt treatment for hydrocephalus. And so what does it mean now? Well, it means that this part should be adjustable as well as this part. One possible explanation why it's so important, I think it's easily understood, considering the growth of a child. As more the child is growing, this distance becoming bigger and bigger and bigger. And what about adapting the gravitational force then to the growth, for example? So how could this work and how does it work? So the adjustability, I mentioned how gravitational forces work. You have here a gravitational force which is counterbalancing this hydrostatic pressure here by the weight of the ball. Well, now we introduce a spring which is adjustable. So this can bend, and the elastic deformation is acting against the force of the gravitational ball. You can see it on the next slide. I adjusted, tried to move it up, this ball, and hereby lowering the impact of the weight because it's counterbalanced by a spring force partially, and therefore the compensated hydrostatic pressure is decreased significantly. And the last stage, even it's cut off, which means the ball is moved up and there's no chance for gravitational compensation of this device. So here with this technology, we have now two options. We have an adjustable or fixed pressure valve for the lying position and an adjustable pressure for the upright position. In the lying position, I think it's easier to say, well, where's the risk if we have a low pressure valve? And NPH is important as well as in general. I think for the treatment, if a child or the patient is lying horizontally, it's fine. The question is, what is the referential? In average, it might be somewhere at the upper abdomen, but the variation might change depending on individual landmarks. And therefore, it makes a lot of sense to consider to make this adjustable. So what is the graph? Let's say we have now two dependency for this device, which I understand is a little bit confusing, but I think it's worth to be taken into consideration. So at this graph, you see the inclination of the device or the patient. So in the horizontal position, if it's zero, regardless what you have, well, it's always zero. In the upright position now, depending on the inclination, depending on the adjustment, you have different curves, and for sure you would have additional ones in between. Adjust to 10, the maximum in the horizontal and the vertical position would be then 10 centimeters of water, and in the lying position at around about 45 degrees, it's already zero. So this means, well, we can then say, depending on the growth, 30 or 40 or 20 centimeter can be compensated in the upright position. And it can be adapted to individual landmarks. So what does it mean, finally, to conclude? The adjustment of the differential pressure in the lying position, I think, has been overvalued. Very often, the adjustment has been used to address something which causes trouble in the upright position. If we have in this position here a comparably low differential pressure, you will not see any over drainage if this is not the same or going to happen in the upright position. We should address in the upright position the hydrostatic pressure, which is physically in any patient existing, even though we don't see it clinically necessarily for whatever reasons. We could discuss this as well. But in all, however we do that, I would say it's important to be addressed. So I hope that this clinical technical explanations might be helpful for one or the other of you to consider clinical complications you have been seeing, or an explanation of something which have been somehow confusing. And I'm more than open to start a discussion about any question or any comments. I'd like to thank you with the slide from the castle of Sanssouci in Potsdam, where I'm living, a beautiful place here in Germany. And I'd like to thank you for your kind awareness and interest.
You're muted, Ahmed.
Okay, thank you very much, Christoph, for your very great presentation. That is really, you succeeded to present in very simple and clear way the problem of over drainage and the ways how to solve this and how to avoid it. Now, I think you provoked a lot of questions and actually inspired a lot of way of thinking and the question. So, Marianne, please, do you have a comment to those questions?
Yes, I do. Thank you, Ahmed, and thank you, Christoph, for sharing part of your birthday with us. And thank you, as always, for a really excellent talk where you very clearly illustrate principles so that we can all understand what is going on. I think the illustrations are, shall we say, immensely clear to us how these forces act and counteract each other. It's the best demonstration I think I've seen of this. I would also like to thank you for stressing the fact that measurement and assessment of ICP should not only consider the supine position. We have a traditional tendency to accept that as the standard position, although most of us, at least when we are more than 1 year old, and if we're not severely retarded, then we will spend 2/3 or more of our time in the upright position, and that should be considered at least as standard a position. And this is where naturally the question of over drainage comes in, because if we were all supine all the time, we probably wouldn't see any over drainage. So far, so good. So I would like to put a challenge to the panel, because we can all understand how the height of the water column corresponding to the height of the patient, or at least the length of the tube, is a factor in over drainage, and also a factor in how much mechanical extra opening pressure, or extra resistance you must put in to counteract the effect of the water height. However, at least in my clinical experience, there is a big difference in the over drainage tendency, even in patients who may seem identical. Some patients do extremely well with one type of shunts, with one type of valve, and even with very simple mechanical principles. And other patients are very difficult and require a lot of attention and a lot of hardware device to counteract severe over drainage, even though they may not from the outside at least be physically very, very different. So my question is, what are we missing here? What other factors than height of a water column has an influence on the tendency to overdrainage? What sort of other regulatory mechanisms are we missing here? And what can we do in order to have some pre-operative testing of the individual patients to predict what kind of overdrainage protection a patient might need and how much at risk this patient could be to develop an overdrainage, or with this another patient could be more robust? I don't expect you to have clear answers, but it is a challenge and something I see very often as in my own clinical experience. Thank you.
Thank you very much, Maria. This is a very, very important question. And there are many answers, but not complete answers, I say. I think one of the best, the one who can really tell us more about it is Harold Ricke. We said about Christoph, he spent over 30 years in this field, but Hal, he spent over 40 years dedicated to this field. Hal, please, can you go ahead?
Yes, I'm very happy to do this. And I want to congratulate Professor Mitke on his discussion. The videos were really quite helpful. I wonder, the problem is, should we all have venous shunts rather than peritoneal shunts? Because then you would have not nearly as much difficulty with the overdrainage. That's number one. Number two, I would like to have what Christoph would say about that. The other one is that for Marianne, the problem is where is the blockage? Essentially, all hydrocephalus relates to a blockage, and so one of the things that shows why some people have a more difficult problem with overdrainage than others is where is the blockage? If the blockage is in the aqueduct of Sylvius, that's the worst thing you can have, because there will be no other ability. All you're doing is draining only the CSF out of the ventricles and not from any other place, which tends to bring the brain inward. That's where you get your overdrainage, where you get your slit ventricles and all of that. If the blockage is out of the fourth ventricle, then you're going to see a major increase in the size of the fourth ventricle when the shunt isn't working. If it's in the cortical subarachnoid space, then you have a lot of CSF to drain, and they will have much less trouble with the overdrainage, because it won't suck the CSF specifically out of the ventricles. I think that all of this is a statement that we should, even if we have to have a shunt, it's better if we open up as much CSF as you possibly can. One of the things that I've never been able to understand is how things stop getting lower and lower and lower. When you stand up, all of us are now in an upright position, spinal fluid is going into the spinal subarachnoid space, and but when you lie down again, it immediately returns. Whereas once the CSF goes through a shunt, it can't get back. So it has to be, something has to be, by the Monroe-Kelly hypothesis, we have to have something in there to fill it up, to bring the pressure back to where it is. And that's the major problem you're dealing with. The more CSF that leaves, the more CSF you have to make. So the idea is to try to minimize the amount of CSF that goes through the just enough to keep the ventricles from getting larger and problems to happen. I'm real believer in the more access to CSF you have, the better the shunt is going to work and the less that overdrainage is going to happen. So I think that if you have an aqueductal stenosis, even if the third ventriculostomy doesn't work, it's still going to make a better outcome it's very, very likely that it'll make a better outcome for the patient, and you'll have less difficulties with shunt revision after shunt revision after shunt revision. Anyway, I would, if you're really worried about overdrainage, then putting the end of the shunt tube at the same level as the head would be one way that would really help. And we're now seeing work being done where the endovascular people are looking at getting a shunt without having to have a surgical procedure, really. So I think that's really exciting. But I've learned a lot from Christoph today, and I appreciate what they're doing. Somebody's going to look at these question and answers, and I think that should be passed over to Andre, who is the answer person.
I see that. I see, but I think that Marianne has raised her hand, probably wants to immediately react.
Yeah.
But we have to watch out that this will not be a discussion just between the two of you, because a lot of attendees have also questions.
I will just very, very briefly comment. I absolutely agree with Hal that the worst thing that can happen is if you create different pressures in different compartments, and you need to ensure that the pressures are equalized. And if you combine an ETV with a shunt to do that, I think that can sometimes work as an excellent solution. My own idea about what we're missing is that we're missing the venous regulation of the ICP. And if we put in a shunt to the abdominal cavity, we bypass this important regulation of ICP and volume compensation inside the skull. And I think a major problem is there. So I stop with this now to make room for more.
And actually the first question that was in the Q&A was from Dominic Tilgensberger. He said, why does not every patient get overdrainage? Because we all are laying down, we are all standing up. And he said, and the second part of that question was, what's the role of the venous system? Don't we underestimate that indeed? Christoph, could you address that?
Sure, not everything, but the technical point of that I would like to address. And this is, you know, I remember several situations where I've been asked the same question. You know, there are individual differences regarding, let's say, dimensions and individual pressure situations and etiologies behind. For example, if you have a situation where a pressure situation can be established at the different compartments in the same level because there is a connection, and then your overdrainage is a completely different. For example, if you would drain someone with an aqueduct stenosis, where you have an isolated drainage, and then you establish very soon, rapidly, a negative pressure and the suction to the brain. I think it depends partially on the situation of the strengths of the tissues and of the let's say the real anatomy in the individual patient. Some doing well, even though the pressure is always the same. And therefore, I believe then, well, why the adjustability of the gravitational force is important, because if we talk about NPH, I know, yeah, maybe you know the paper from Pang and Altschule, they probatorily lowered the opening pressure to establish a negative as a treatment option. I call it a non-invasive spinal tap test, and then patients are improving afterwards. So some people are taking benefit from overdraining, but not always. So I think, so why not for everybody is going to be dangerous? I think you cannot predict for whom it is. And it's the same, I would say, at least like an airbag in a car. Yeah, if you don't have it and you have no accident, then what does it matter? But if you have an accident, it makes a difference. And if you could predict who's going to have an accident, this would be great. Then we could skip the airbag. And we should carefully consider the upper position regardless, because physiologically the counterbalance makes sense to that the pressure remains there.
It's very nice, because it addresses also one of actually the last question in the series. We come to the others of Magda Garzon saying, I just think that the lack of elastance, so compliance of the ventricular wall, plays a very important role. And this has been poorly investigated. I also would say poorly understood. But maybe this is more for Hal, who knows a lot about this part of the equation, if I can say it that way.
Yeah, I've spent a lot of my time working on the elasticity of the brain as well. Probably if the venous pressures were higher, then the overdrainage would be less as a matter of being negative pressure, because the ventricles would prevent it from getting much larger. And it's a very important part of the thing. The issues especially are due to what happens when you have hydrocephalus in infancy. And Christoph started off with the discussion of craniosynostosis as one of the things that happens with overdrainage, and that's really important. It's extraordinarily important in infants, because if you do if this infant has overdrainage, then their skull will be, inches thick, and then when the brain finishes glowing, it will push it out. Now, the brain will still get to its proper size, but at a cost, and it makes it very, very difficult. So it's the more we know from the African study and all of that is that we're shunting way too many babies, and we should hold off longer to get the cranium a much more normal size. So you don't want to have a very small skull. And I think that plus the stiffness of the brain all work out together. So it's not I think it's important to know that it's not a shunt, it's a sentence for little babies. And you have to give some real thought to when you go ahead. You can't, the things that we talked about today are not something that you think about much in babies, because they don't spend much of their time upright. But the higher the pressure you can get, the less drainage that you can get, the better it will be for the child for the rest of their lives.
That's true. Chris, if you want to react to that, I saw your hand.
Just a provocative question to you to discuss. What do you think is more important, to focus on the survival rate or to focus on the head circumference of the newborns?
I'm not sure I understood the question.
The question is, from my point of view, I remember when I started working in shunts, pediatric neurosurgeon said, most important is that I see the shrinking of the head and I see that drainage is working. So the children were treated. And hereby establishing slit ventricles. And you can see if you measure the normal growth of the skull by looking at the head circumference, I would simply follow that. And regardless whether I need an additional surgery or not, I would say do the surgery to get rid of that. I think it's similar to what you said, Hal.
Yes.
It's important to get rid of the shrinking, because this is a horrible situation. And very often I met patients, or here and there I met patients, at the age of 20 and said, first 10 years, my shunt was great. I would like to get the shunt back. And then I say, well, this is a guilty one. It did not establish physiological pressures. So instead of looking at especially the survival rate, we should focus on the physiological growth of the skull for these children.
Yep.
Can I just one more thing, because this is extraordinarily important. Extraordinarily important. The work that Ben Worf has done and is in the team would tell you that it's really the most important thing is the volume of the brain. A volume of the brain, if it's a normal volume of the brain, the patient's going to do well. regardless of what the ventricle looks like. And so I think that we have,
very, very
as I
significant.
said, we've got to do fewer shunts in babies, or maybe wait a long time before we do it, so that we have a normal thing that keeps the skull from getting too small or thick. So you're right.
Think that, I think that is very important what you are saying, Hal and Christopher. Actually, there are, as Marianne mentioned, there are many factors like venous drainage and also the parenchyma, the volume of the brain, and the compliance of the brain itself. And then came the question about the elasticity of the ependyma on the wall of the ventricle. And here there are several factors which really we may not study very well, but we see in the clinic. There are different, for example, to drain or shunt a child who had intraventricular hemorrhage before as premature also, or another one after meningitis, or another one of, for example, with bilirubin, high bilirubin or high. The ependymal wall itself, and it is important that at least it is surrounded, or it is in the wall, is the chemistry of the CSF in the ventricle is normal. Alteration of the chemistry of the CSF in the ventricles, it may affect a lot the elasticity and the compliance of not only the ependymal wall, but also the surrounding brain tissue. So, is there other questions?
Yeah, there are some more questions, and of course they are not all exactly in the same subject. But this webinar was mainly also on physics to understand what overdrainage is. And one question is from Uday Gupta in India: does increasing the head inclination decreases ICP? And does it decrease also if you do more than 30 degrees? Because it was said that when you have the 30 degrees elevation, the ICP goes down. Does it go further down when you elevate it more? That is the question here.
Well, we actually did some studies to answer exactly that question. We performed ICP measurements, diagnostic ICP measurements, where we did a head tilt down and head tilt up to various degrees. And what we could show was that relative to the supine position as the 0 or reference position, if you tilt the head down, you get exactly the ICP increase, which corresponds to the hydrostatic column. If you tilt upwards, then you get an ICP reduction corresponding to the hydrostatic column up to an elevation of 30 degrees. Beyond that, you get very little further decrease of the ICP, meaning that it's not solely a passive hydrostatic column, and there is some sort of physiological or biological countervalve which prevent the ICP from dropping drastically. And that is where the idea of the venous biological countervalve comes in, that it is a possible way to biologically keep us from dropping our ICPs when we stand up. We further expanded those experiments by putting a suction device on the patient's lower body and lower extremities to pool the venous blood in the lower part of the body. And we were actually able to decrease ICP doing that, demonstrating that, or at least indicating strongly that the way the venous blood is distributed and the way the neck veins work are probably a major regulatory mechanism in ICP, and something we should consider when we put in shunts, as Hal said a bit provocatively, should we put them all to the venous system? Well, if the venous system is a major regulator, maybe that's not such a bad idea.
That's right, yeah. Well, there are at the moment no other questions really related to the overdrainage. There are some people asking about the best type of valve, but that is not the subject of this webinar. In certain cases, that is not what we wanted to do. I think we should really focus on this principle of, and that is already difficult enough. And as you have shown, there are some physical principles. I love those videos to see how the drops goes quicker or slower, or stop doing that by and moving this membrane. This is very, very illustrative. And also some parts of practical questions that we have sometimes as neurosurgeons. I was surprised by a few of your slides showing that the atmospheric pressure has a big influence on the ICP. And well, if you have high atmospheric pressure, that would be in the summer, so the time coming now, and then way lower, 960 bars in the winter. Would that also point to the fact that you will expect more over drainage in the summer? Christoph?
Yeah, a second, I just lower my hand. Yeah. I wanted to say that we easily get adapted. So if we climb a mountain, maybe everybody experienced that. We are climbing the mountain, then we make this movement to adapt our pressure somehow to the changing absolute pressure. Yeah. So and the same happens, for example, if we have a low pressure situation, it's raining and so on, our differential pressure is the same level because we adapt to the outer pressure. So our pressure always follows the atmospheric pressure, but we are able as a healthy person to add a physiological pressure which is above the atmospheric pressure. Always.
Is that also in a shunted patient? Because we just heard that the CSF is gone. It's not just moved out in the subarachnoid space and then returns. It's gone. It's resorbed. And maybe that is also very nice because you said about the altitude. I still remember that in the 80s, there was even in the booklet for shunts, the advice that a shunted child should not be in an area over 800 meters of altitude. It's not anymore, but can you imagine what we do as doctors when we give this advice to patients, which is of course a useless advice?
From my point of view, this underlines the importance of communication. I think this is one of my personal approaches to share what I see, what I believe, which does not mean that I look at the things from this physical neurosurgical perspective. But we have to add this. We have to understand, what let's say the artificial influence is, which is always coming from a shunt. And for sure, we have to add as well the other side, which I'm far away from. I'm just focusing on what I remember I was talking about. Let me know what kind of shunt you would like to get. And well, my personal answer was collecting all the answers. Well, a good clinical outcome without complications. Yeah, and this is not a technical explanation. And so, how can consider now as an engineer what could that be? Well, one thing is we consider our own thoughts and say, how does it work? Then we explain that and bring on the table that this can be discussed and shared, and stepwise we can develop something. And the confusing sentence, not climb a mountain or don't dare to dive, I would say, forget about that. If you have anti-siphon device implanted, well, I give the question in the group. So this device with the membranes. So if you're now diving, the outer pressure is definitely increasing on the large area. I would say diving is for these patients not allowed, even though if you dive for 5 minutes and you have no drainage, it's not dangerous, I would say, because then you have no drainage, you come back and then you could drive. But physically, I think if you dive, this interferes with the situation. With DP valves, no.
Maybe another question is also about the length of the distal catheter. We know that it is quite a long distance, and especially if you have a very young child or even a premature baby, it sounds, sometimes it feels a little bit odd for us as surgeons to try to get in this little abdomen all of this tubing. Is there an influence of the length of the catheter? That's the question.
So shall I give a comment on
Yeah,
that?
maybe just a technical one. Yeah.
You know, I skipped the slide for today, not to put too many things into that, but for sure the resistance of a tube has an influence on the resulting pressure situation in the proximal part. But all the shunts are designed with an average, they have an inner diameter of 1.2 millimeters, regardless who is manufacturing them. And if we add 30 centimeter of water, this is not really important as in terms of increasing its resistance. Normally, the pressure situation is established by the valve system and not by this tube. I remember Alfred Aschop always recommended to implant, instead of a catheter with a diameter of 1.2, he always said 0.8 would be better. If we have such a tube, it would have an enormous impact. But this is again over drainage, which we should address with a let's say technical approach of the devices. But it could be, or it is one option, to use this resistance to counterbalance or to address over drainage.
And therefore, maybe directly regarding this question, there is from Ashraf Al-Sayed. Would you recommend an anti-gravitational device in every patient that needs a shunt, or only as soon as they develop low pressure symptoms or over drainage?
Well, I think that all patients are at risk of over drainage. In some patients, it may be severe, and in other patients, it may be subclinical. But everybody, apart from a few, stands up. So I would strongly recommend, unless there is an obvious argument against it, to actively counteract over drainage.
So you rather want to prevent it and not treat the condition?
For the reasons that Hal said, that
yes.
once you have it, and if you let it develop, especially if you let it become chronic, it can be extremely difficult. You empty to state it in a popular way. Once you've emptied all the compliance out of the system by overdraining the ventricles and making a lot of physiological and anatomical changes that become permanent, then it is very difficult and close to impossible to remedy and turn physiology back to normal or almost normal conditions.
Yeah, that's true. That's absolutely true. And there is maybe also, because we consider now drainage and over drainage, Sofia Chosnica has now asked a question, or maybe a statement, saying that increased activity of slow vasogenic waves can also increase the drainage. It's not only, let's say, the passive things that go through a shunt, but it is also the physiology of the brain and the way it drains. And we know, of course, also about the different pressure waves in this. Any comment on that statement?
I would like just to give one comment on the question of compensating this overdrainage in all patients. I think there's one group where I would consider not to do that. If you have a patient who has been drained for a long period of time successfully with a DP valve doing well, and then, for example, there's a rupture, and but the DP valve has established this physiological situation, patient has had no complaints about the situation. And then I heard of cases where they changed to the gravitational compensation, establishing a more physiological situation, and this again introduced sometimes difficulties. So if a patient is doing well with something for whatever reason, and maybe then I would recommend to simply do the same and repair it.
And there is one question on, would you also recommend gravitational units in lumboperitoneal shunts?
One brief comment. You know, I remember in the 90s, maybe everybody is aware of Van Este, yeah, and Shizuo as well, with LOFA. They said, well, we shouldn't dare to implant a shunt in these patients because of risk of overdrainage. and with the herniation of the brain, it's going to be very, very dangerous. And then I think this is one of the reasons why people stop implanting lumboperitoneal shunt regularly.
At least in normal pressure hydrocephalus, because that was fast.
Because then it's sucked into the distal part and increasing enormous risk. So the counterbalance, I'd like to remember that there was this horizontal vertical valve. This was designed as a gravitational valve for LP shunts, and I did always wonder why not for VP. It's for both. Physically, it's the same. And
it's the same.
It's even more important.
Yeah, that's very important. And maybe
Well, one of the things that's really important is don't ever use the off the shelf LP shunt that you have just one piece that keeps going. That's going to be horrible for the patient forever. And so a valve needs to be put on. There's no question about it, whether it be one of the anti-siphon device things, which is fine, or a high pressure valve, because it's all at the same level. The lumbar theca and the abdomen are at the same level. So I don't think it's not a matter of suctioning. But they absolutely need a valve. And I think the Japanese, essentially all NPH is treated with lumboperitoneal shunts.
That's right. That's absolutely right. And also in intracranial hypertension. There was an interesting article, not many people read it, but about young female obese patients having intracranial hypertension, receiving this lumboperitoneal shunt without a valve. And then after that, they had bariatric surgery. So they lost weight. And after losing weight and still having that drainage in, they all developed overdrainage symptoms.
Yeah, I would tell you that I've published on this too, is that the treatment for bariatric patients who have pseudotumor, obese patients who have pseudotumor, the treatment is bariatric surgery.
Absolutely.
And if you start off with that in your mind, then the drugs will hold it over so that the problems with the eyes can be maintained for a while. And then and we showed that the ICP and the venous pressures go down dramatically after bariatric surgery, and it's the right operation for that rather than a shunt. Again, it's not a shunt; it's a sentence.
Fully agree. Christoph, a remark on that.
I add one, from my point of view, a very important remark regarding, we are talking about overdrainage compensating device, and I gave an overview about the 3 types. Yeah, and for lumboperitoneal shunts, one of them does not at all work. This is an anti-siphon device, which is depending on the membrane, because this differentiates between the proximal part and distal. And if the proximal part is already the column of the spinal canal, then it's always opening, not compensating that. I just want to underline that.
Oh, that's right. And therefore it's so important that you explain these physical principles of all these devices so that you know why you are actually using them. Marianne?
Thank you, Andre. I absolutely agree with everybody that you need to match whatever you do to the kind of problem that you're facing. We haven't used shunting for IIH patients as a primary treatment, or even as a secondary treatment for a really long time, and put in very, very few shunts in IIH patients, because the problem is a different one. And the problem is probably one of venous hypertension for one reason or another. And letting out CSF from a ventricular compartment, which is already narrow, it seems, shall we say, counterintuitive, and is also facing a lot of problems for this patient.
Actually, it doesn't work when they are still obese, because the intra-abdominal pressure is so high that they are actually not draining at all. But the moment they have bariatric surgery and decrease their weight, it starts to running out. Indeed. No, but I don't see other questions, but there was one more, let's say, suggestion for the future of an anonymous. I said, is the answer maybe just an electronically controlled device that can measure the pressure difference and only open at a set value regardless of the position, with no mechanical parts to be affected by gravity or other thing, just something electronically measuring pressure difference, and only that we will open or close the valve. Do you think Christoph, this would be something we would see in the future?
Yes, I think a Japanese guy, Nobu, maybe all of you know him.
Yeah, I know him by name.
He's working on something like that, what he calls a smart shunt, which is open electronically according and adjusts itself according to the pressure. It is done experimental yet. It's not the final design, but I know we are good friends. He told me that they are working on something like that.
Okay, well, I think it's just fair to have a final remark from Christoph.
Okay. I would like to give a comment then on the electronic approach. Because this is, I would say, from the early beginning when I started wearing shunts, it was a comment. This would be an easy answer. I would like to give one thought to that. What is the challenge? It is the atmospheric pressure, which is going to be established depending on the weather. And the differential pressure is what worries us regarding the ICP. So the system would include an external transducer, which is measuring the atmospheric pressure inside the body, measuring the absolute pressure, calculating the difference, and then establishing something which is allowing a drainage or not. So this is introducing not only significant risks, it is including as well requiring a size, a volume, an additional risk regarding battery and pressure transducers. What is your experience regarding pressure transducers within external drainages? How long do you trust them? We have to trust these transducers for a very long period of time. And I used to say, and then I stopped, before we don't have such a transducer, we are not able to think about that. But we have been working on such a transducer, and now, we know that the transducer is available, but too thick, being used in a shunt. But we will see what the future will bring.
Yeah, so there will be still a future, and there will be developments. I mean, we have not discussed it yet. We had only 2 webinars until now. First on the principles of shunting, and now over drainage. There will be other seminars, and I think that now I give the words to Ahmed to close the session.
Thank you very much. And I would like to thank all the attendees to this very interesting and useful webinar. And of course, thank you to the EANS and Anna for organizing it. And of course, Mansour for sharing it. And special thanks to our guest, Christoph Metike, for his super and outstanding lecture. And of course, to our great panels, Harold Riquet, Marianne Jolar, and Andrea, and for everyone. I think we will announce soon the 3rd webinar. Now we talked in this first webinar, we talked about the basic principle of hydrocephalus and the intracranial pressure, how it is, how it's regulated. And then we talked about the technology. I think is that the time come in the 3rd webinar, we talk about clinical cases to demonstrate all what we have. I think we will have it within 6 weeks. We will find the date exactly, and we'll let all of you know. So thank you very much. Thanks to everyone shared in this interesting webinar. I think all have learned a lot from it, and we will see you in the 3rd webinar within 6 weeks. Thank you very much.
Very good. Wishing you all the best. Bye-bye.
Thank you.
Excellent team. God bless. Wonderful.